When I talk about anatomy, of course, everybody knows something about anatomy. And so it largely comes down, the structures don't change from year to year. The structure are always there. It's just a matter of how do we define them? How do we name them? And how do we reduce the confusion that happens with distal radioulnar joint? Now, I don't have PowerPoint slide access anymore, but I found as I'm teaching the fellows that it actually has been an advantage to me to not use PowerPoint or not use videos. If I make a drawing, you can kind of see it develop from the beginning. And so I think there are many more opportunities for us to understand some of the complex anatomy of the wrist. But I'm going to be a little bit of a renegade here by not trying to add to the complexity of our understanding, but try to reduce it down to the simplest essential features. We don't want to reduce it to the point of error, but we can certainly reduce it to the point of getting rid of the confusion. And I'm just going to use things that I learned along the way that dramatically helped my level of confusion and level of understanding. And I'm going to try and share some of those principal points with you. For my co-faculty here, I will apologize in advance because Lord knows you've heard this from me a number of times. So I do apologize for that. But let's just start off with the distal radioulnar joint. When we look at the DRUJ as the abbreviation for it, it's actually part of the entire forearm joint, which includes the PRUJ up near the elbow, the DRUJ, and the interosseous membrane. But what we're going to concentrate on today is the DRUJ. And it's composed of the ulnar head and the distal radius. And one thing that we'll notice is that as the ulna articulates with the radius, its radius of curvature is smaller than that of the radius, which means that the dimensions of the ulnar head don't fit exactly in the sigmoid notch. They're actually a little bit smaller when it comes to the curvature. And what this does is this establishes the possibility of anterior and posterior translation, which is incredibly important. If you eliminate that anterior and posterior translation, you will severely restrict the range of motion of the forearm joint. We need that translation in order to have a functional forearm. Now, would we start off at the level of the soft tissue of the joint, for example? One of the first things that was always a misconception for me was eliminating the idea that the distal radioulnar joint ligaments drape over the dorsal and volar aspects of the ulnar head, thereby constraining it. Not true. Not true. These are actually like collateral ligaments. They're fine. They're actually a little bit distal, and so we don't get any direct effect of draping the ligament over the joint. We get stability and control of the joint with the articular surfaces, even though they're not congruent, they still offer stability, but also the collateral ligament system of the DRUJ. So when we're trying to reconstruct something, we do not want to go across the dorsal surface or across the palmar surface with any kind of a repair or reconstruction or ligament augmentation or anything. I'm going to be stressing to try and anatomically return to the roots which got us there, as it were. Now, the first layer that we're going to run into is the deep layer of the ligaments, and they originate from the dorsal and palmar ligaments. Originate from the dorsal sigmoid notch and the volar sigmoid notch, and they converge towards the ulnar styloid process in a region that we call the fovea. Okay, right there. And fovea just means shallow pit or depression. And what it turns out, it's not only a source of muscular attachment and very strong, ligamentous attachment, but there's also a substantial vascular invasion in this area. And this is the area that's called the ligamentum subcruentum. And what that stands for, I'm sorry, it's just such a confusing term, is that this is the ligament that's below the cruciate ligaments of the posterior and anterior radial ulnar ligaments as it inserts into the ulna. That's the ligamentum subcruentum. That's all it is. And I would ask you to now forget that term. Okay, you don't need to use it anymore. Well, I'll probably be wrong with that. But anyway, the other thing about the dorsal and the palmar radial ulnar ligaments is you cannot see them from the radial carpal joint. You have to be under the TFCC in order to see it. And by under, I mean proximal to the TFCC. That's the only time that you'll be able to see the distal radial ulnar joints, ligaments, as far as the deep components go. Now, we do see ligaments in the TFCC more superficially, but that isn't part of the stabilizing deep part of the ligament. So just remember that the dorsal and the volar ligaments are converging towards the fovea after originating from the edges of the sigmoid notch. Okay? Now, it's important to remember the fovea because in my clinical practice, the one place that we had dissociation of these ligaments, it occurred with what we call a foveal dissociation. And I don't know if you're able to zero in on this little drawing here, but this is the way that the TFCC normally arcs over the distal aspect of the ulna. When we have a foveal dissociation, this avulses off of the ulna and progresses distally, but in doing so, it takes out of commission both the dorsal and the palmar radial ulnar ligaments at the same time. Okay, so as far as I'm concerned, you know, if you're managing these things in the emergency department or wherever, just consider if you've got instability, it's going to affect both the dorsal and the palmar or volar radial ulnar ligaments. It's not one or the other. You know, the whole argument with Schwind and everything, the dorsal ligaments taut during pronation or the volar ligaments taut during supination. It doesn't matter. It doesn't matter to me because both ligaments are compromised in most traumatic disruptions, whether there's a bony fragment or not. Okay, so I like to use the physical exam at this point and let that direct me to which tests I want to order to confirm that, not getting the tests first and deciding what the diagnosis might be. Okay, I'd like to depend upon the physical examination first. Now, as we move distally or superficially, we're going to run into an area that we call the superficial part of the ligaments. And this is what Bill Kleinman refers to as the essentially the quadriga effect. And this is what gives the cut or the depth to the radial ulnar joint, is that this projects a little bit distally. And so we have a recess here that the triquetrum and the lunate articulate with. Okay, that's what gives the three-dimensional cuff to this area. And as we rotate the forearm, of course, that goes with the radius moving around the ulna. It's hard to remember that sometimes. A prominent ulna dorsally is not a dorsal dislocation of the ulna. That's a pathology of the radius, but we have a hard time remembering that. But just try and remember that both the dorsal and the palmar radial ulnar ligaments are compromised in DRUJ instability. Now, as a result of this arrangement, we can begin to start to see some unique features of the ligaments in the region of the distal radial ulnar joint. For example, with this dorsal radial ulnar ligament, we're going to see some fibers that split off and actually form a subsheath for the extensor carpi ulnaris tendon as it goes through the groove between the ulnar styloid process and the ulnar head. So this subsheath is actually part of the dorsal radial ulnar ligament. I don't think that it imparts any different properties to it, but it certainly helps to stabilize that extensor carpi ulnaris tendon in the subsheath as we rotate the radius around it. So it's almost like a pivoting axis. That the ECU tendon is held in place by the by this subsheath that continues on distally over the triquetrum and even into the region of the hamate as it surrounds the extensor carpi ulnaris tendon. But it's no longer associated with the distal radial ulnar joint at that point. Once we pass the dimensions of the ulnar head, we're no longer dealing with the DRUJ.